for bearing still with us after that little shift in venue. Well, this is the What's in It for Data Research Users, just to make sure everyone's in the right room, which is great. My name is Christofidou. I am a jurist, a researcher, and a PhD candidate under IHV, the European Institute for Innovation for Health Data, and a PhD candidate under the University of Ghent in Belgium. I am going to be stepping in as moderator in place of WifORInstitute, who unfortunately couldn't make it today. But I'm equally as excited to present the panel today and to step in and listen to the discussions. I certainly have a lot of questions myself, but I will try to put those in the back burner and let you and the audience online ask questions in advance. In terms of the presentations, we have 3. So depending on how we do for time, we probably will have the 3 presentations and collect questions towards the end, just to make room for that, for questions online and then a discussion. I will give a very brief introduction to our presenters now, and then let them get on with their presentations. To begin with, we have Koenraad, the head of the government of Flanders and the Department of Information Policy and Data. Then we have MiguelÁngel Armengol. I hope I didn't butcher that too much. Who is the head of the regional Ministry of Health in southern Spain in the Big Data Department. And then last but not least, we have Emmanuel Alexandrakis, who is the Health Economy Global Strategist at WifORInstitute, and also a professor in the health sector strategy at the Athens University of Economics and Physics. So to begin with, please take it away. Thank you very much.
Thanks for the intro and thanks for the invitation. First of all, I can talk this morning or this afternoon regarding with my topics, so please keep track of my time. So I work at the Flemish Agency of Health and Care and the Department of Welfare in Flanders. And I'm going to take you on a journey with respect to the origin of the Care Atlas platform. So I'm going to show you how we are using data on a day-to-day basis on a government level, also in the COVID-19 period. First of all, disruption. It's the buzzword, the keyword of the past few years. There has been several disruptive waves. First of all, we had the digitalization wave, not only in the private sector, but also in the public sector. Then, of course, we have the acceptance of machine learning, artificial intelligence by the public, by the society, and even for the first time, we have a robot pass the medical licensing exam. So also the use, the practice of artificial intelligence in the healthcare sector. What you see here is a study that has been done with 1,082 Flemish citizens. The question there, it was performed in 2020. The question there is, well, am I willing to share my medical data, yes or no? So on the left, my data can be shared to develop new medication, train doctors, achieve better results in future. And then, of course, important is the context of use, a doctor and an algorithm. The scale, 1 means totally not agree, and 5 means totally agree. So what you see over here is that there isn't that much difference between using your data by a doctor, by a person, or by using the data by a machine and algorithm. So that's already good news. When we look at the right table, there you see the type of data that the people are willing to share. We have medical file, age, medication use, sex, family situation. But in the former session, there was a lot to do about using information from apps and using information from smartwatch data and so on. You see there that we already dropped to 20% to 50%. The next disruption or the next wave that we see here is that the past years we have seen that the business models, in the beginning the product was placed central, now the person, the customer is going to be placed in the central point. And we talk about customer journeys. Of course, you can also talk about the patient journey. But what I'm willing to do, or what I'm going to do in Flanders, is I'm going to lift it up to government level. What I'm willing to do is, from the cradle to the grave, I want that every Flemish citizen that has a specific touch point in his or her life, I want to be able to capture that information so that the Flemish government can see if our investments, the money that we can get from our taxpayers is well spent, yes or no. So that we can come to more data-driven policy, so that we can act more quickly to things that change in the real life. So I'm starting next year a 2-year program with Armengol, so that's a research partner in Belgium, where I want, on the one hand, I want to set up a Flemish health data space where we're going to capture every health data information or welfare information with respect to the Flemish citizens. And we are going to check what are the ethical issues, what are the privacy issues, what are the technical issues. And at the same time, also want to start developing a digital twin. And there are a lot of projects going on with respect to digital twins, more focused on geographical area and on twin cities. But what I want to do is I want to make an avatar of a Flemish citizen with respect to the different touch points that he or she has with all the healthcare providers in Flanders. For me, population health management is a concept, and it's not that easy to give it a correct definition to it. For me, I have different subpopulations where I have to give service to. In the middle, in the center, we have our citizen, but around we have the first line care providers, we have the second line care providers, we have the third line care providers, and of course, my region, the policy. So we need information on a micro level, on a meso level, and on a macro level. So what we did in Flanders is we developed a Care Atlas platform that is going to capture external information. We're going to uplift it by linking it to internal databases. We're going to analyze it. We're going to make descriptive predictive models. We're going to make visualizations, and we're going to put all that information back to the different stakeholders in our health landscape. For instance, say that for every Flemish citizen, he could give to that person back information about, well, taking into account your social demographic parameters, taking into account your use of mobile health apps, taking into account your BMI and other pathological applications, what is the normal health path that is being followed by your peers. So we are going to be able to give back to the patient, to the citizens, to the consumer, to be able to compare my usage with respect to my peers. So that can give me information if I'm on the right track, yes or no, and so we can focus more on preventive actions than on curative actions. Okay? So we can get information about life goals, we can get information about care goals, and so on. The other thing is that in Flanders we have 60 first-line zones. Every first-line zone has a specific care council. Care council is a combination of local players, is a combination of medicine, healthcare institutions, and so on. So what I want to do is I want to give back information to those specific first line zones so that again they can benchmark each other, so that they have peers, so that they can decide, well, if I look at the first line zone in Ghent, I see that they are doing better with respect to specific subpopulation than my care zone. So I can go over to those guys and try to communicate and get some information. How does it come that you're doing better than we? So I want to give back information on the local government level. That's very important. Another aspect is that we want to do some longitudinal analysis. We want to see within my population, do we have subpopulations? What are the characteristics of the subpopulations? And is a person going to change from one cluster to another over time? What is the reason for it? And can we act on that? Yes or no? Of course, another huge disruption was COVID-19. So what we did in Flanders is we started with setting up a care atlas. The idea of the care atlas started in 2018. I foresaw there a throughput time of building that care atlas platform 3 years. Due to COVID-19, we had to do it in 3 months. So first of all, we started with it based on specific questions that we get due to COVID-19. For instance, what is the number of contamination of the elderly care homes? It was a huge crisis in France, but also in other European countries. We had our own information channels like the ELOCAT of my agency, but, and of course, when I showed that to my DPO, I talked about Google Forms. There was a little bit of panic because I used Google Forms to get information about contamination and deaths in elderly care homes. So what we did is we developed our own data entry platform to cope with that aspect so that it's more secure, private, GDPR proof, and so on. We also have a website link formula or a module because the public, the press wanted to know what is the situation of COVID-19 on a day-to-day basis in all the specific healthcare institutions in Flanders. Another important aspect is the majors, but I'm going to give more detail that later on. Also had our own machine learning environment where we predicted on a weekly basis what's going to be the take-up of contamination in the hospital and intensive care units and so on. We also had a scientific research platform environment where we're going to work with the WizKids of the Flemish universities to build some predictive models with respect to COVID-19. And we also have different file upload zones and an API link. What I show here is that we started with that Care Atlas platform with a huge focus on COVID-19. What I want to do now is I want to use that same Care Atlas platform with all those different modules, but not only for COVID-19, but also day-to-day basis, also non-COVID-19. Those are some examples of things that we are doing now on a day-to-day basis. What you see here is the Flemish control tower. So based on this control tower, every major of a specific town in Flanders could see on a day-to-day basis what is the status of contamination of COVID-19 in this day, the past 7 days, and also the prediction of the upcoming days. So this was a situation, sorry, too fast. Okay, so this was a situation, I think, in 2020, and of course, this is a situation, I think, in September of this year. So the more green, the better, of course. But this was information that was passed on a day-to-day basis to every major. So a major could decide which actions to take on a local level. More precisely, every major could drill down to a statistical sector. A statistical sector in Flanders is a combination, is a cluster of 10 streets. So every major could see what is the status of the contamination of a specific statistical sector, and again, could act on it. Moreover, there was a pandemic going on in the society, but there is also a pandemic going on in the different healthcare and elderly care homes and so on, so in the healthcare providers. So at the same time, we positioned our specific healthcare providers on the map so that the major could see, well, if there is a specific healthcare provider situated in a map where there is a high contamination of citizens, well, I could close that elderly care home or I could take some other actions. So they got this information on a day-to-day basis. What you see here, every dot represents an elderly care home, where on a day-to-day basis we could say what is the level of contamination of COVID-19 of the people that were living there, but at the same time on the y-axis you could see what is going to be the dropout of the personnel with respect to COVID-19 or other things. So we had a matrix. The elderly care homes that were red, of course, they had a high percentage of people that were sick due to COVID-19, but at the same time they have a high percentage of personnel that was also sick. So we could again contact those elderly care homes and try to help them to cope with that specific situation. So this, of course, was also on a day-to-day basis. This is a follow-up of the vaccination campaigns in Flanders, and every dot is representing a specific elderly care home. We did not only do it for elderly care homes, this is also for the schools, for the universities. So it's also important that the COVID-19 is not only focused on society, not only focused on elderly care homes, but also on the contamination of our students and our tutors. So again, a lot of information that we gathered, a lot of data quality issues, and I'll come back to that later on. But it's the use of information that we got from our healthcare providers. We combined it with internal operational data. We linked it together and we put it back to the society so that they can use it for their own needs. What you see here is the prediction of our different healthcare providers within our policy domain, and we predicted what is going to be the outfall of the personnel. Again, for each sector, we can predict it on a week-to-week basis so that actions could be taken. Another nice thing is we also use the website to publish information and to share. 2 minutes, yeah, and to share information. What we did here is every dot is a specific town, so every major could see how well or how bad he or she was doing. So we put a little bit pressure by publishing this information on the different majors because you could see who is the good one and who is the bad one. Okay, last 2 minutes. I was surprised that this morning I heard about the different OMOP, Fire, Eden, and so on, other nice products and projects. But in real life, in a crisis situation, this is the real life. What you see here, the data quality dashboard. On each evening, we received information of the call agents with respect to those persons are contaminated, so the field agents need to take action the next day. So we got that information day to day by night. What you see here is the quality of the information of the telephone numbers. A telephone number is very important for a person to be able to be contacted and to see which other people that you contacted or know. Well, this is real life. Red means there was no information. Orange means that the length of the telephone number was invalid. And green means that there was information that was usable. This is real life. It was a critical situation. It is for contact tracing. The people needed to give their telephone numbers to be able to see with whom I was contacted the past week. Well, unfortunately, there was a lot of red and orange, so it was not that useful. When we go further on the top, we are talking about the national registry number. So every person in Belgium has a unique national registry number. What we noticed is when we got that information from the contact agents that there were even doubles of a person available in a record. That can't be the case. Again, you see here that a lot of those scripts, the national registry number was empty or was invalid. So again, it's not usable. So we can talk about Eden, we can talk about OMOP, we can talk about other data standards. But this is unfortunately the real life when we are coping with a crisis. The other thing that we developed was a data lineage dashboard. What you see here is that for every dashboard, I was able to show what is our source. So if something goes wrong with our source, and that's on the left side, I can immediately see which dashboards are going to be impacted. So we can take action on that. That's also very important when you're talking about data quality. What is your source? What is going to be impacted on your different dashboards. You see here is the usage. I can monitor when a specific dashboard is used in which moment of time, day and a week and so on. Also when we publish specific information. So again, it's also important when you talk about data quality that you know who is using which dashboard on which time of the day or the week. And the last one, what we also do is, you see here is the refresh follow-up of the different dashboards. So we had about 60 dashboards that had to be run on a day-to-day basis by night, but some dashboards were more important than other ones. So we needed also to investigate how long does a follow-up or how long does an update of a dashboard take, and for instance, we had to push it more back in the time or put it more in front of the time. So those are some things that I wanted to show. How in Flanders, we are using data to bring it back to the population. But for me, population, there are different actions, different actors. You have the person, you have the careholder, you have the government, you have the European government, and so on and so on. So just an intro of how we use information at the Flemish agency. Thanks.
Thanks a lot to the organization for inviting me here. Thanks a lot to Deepak for having me here today. So my name is Miguel, and I'm the head of the Big Data Department in the Southern Ministry of Health, that is Andalusia. And I'm also a research affiliate at the Laboratory for Computational Physiology at MIT, where I spent 4 years doing my PhD and learning about open data and democratizing the use of it. So this is what we are going to be going through today. We are going to be talking about how can we empower our researchers, our data scientists to make better use of the data, of course, always in collaboration with teams of clinicians, of nurses, of other researchers to bring better value to our patients and derive insights from our data. So I really like how this conference is structured, because we are mainly talking about data. And I think this is something we are forgetting very often, because we start talking about AI, or we start talking about research, what kind of answers can we address in the form of tools such as dashboards or clinical decision support systems, or generating reports for the decision makers. For all these, we apply AI, we apply traditional statistics, but in the end, the whole workflow falls if we don't have data available. So I think it's important to remind that we really need an efficient, a safe, a secure access to our healthcare data if we want to be able to derive and accomplish all these things we are always talking about. So about the questions that we were going to be addressing in the panel today, what is it for research users, and do healthcare providers need to learn from their own data? So I think I have a possible answer here. The possible answer, and now let's go to the other side of the ocean. Let's have a look at what they are doing and they have been doing at MIT since actually they started in 1999. This Laboratory for Computational Physiology released FissioNet, which in a nutshell is a marketplace of open data that has been de-identified, that has been efficiently shared, and they put available a whole bunch of tools, of documentation, so people are able to work collaboratively to create community around data, and in the end, as we were saying, to derive insights from the data to apply it to our patients. One of their more popular repositories is Mimic, is a data set coming from the ICU of the Beth Israel Deaconess Medical Center. And in the end, what they were doing was providing, giving the researchers access to vital signs, to trends, to laboratory data, to microbiology data. They also put all the billing information available for the research community. And what they basically did, as you can see here, was de-identifying here the data that was available. They applied date shifting to every timestamp that is available within the data set. And they did a format conversion so the data is more usable for research, because this is, of course, secondary use of data. The primary use of these data that were stored at the Beth Israel Deaconess Medical Center was meant to be used just in the patient-clinician interaction. But this might be sounding too abstract. So as an engineer, when I'm talking to other professionals, what I try is to make things as simple as possible. So I think this might be more familiar, FAIR, the principles that the European Union is reinforcing constantly, so we abide to them when we are sharing our data. So the whole Mimic infrastructure, the whole FissioNet infrastructure, even though it is deployed in the US, has been based on this principle. They fully abide the FAIR, the findable, accessible, interoperable, and reusable of the data. Basically, what we are saying here is that it is not only important to share your data, but also to create community around the data. And for that to be happening, you need tools, you need platforms, you need to document it, you need to allow people to exchange questions, to exchange code whenever they are mining the data. And only through this infrastructure, you can actually make the most out of your data. So this initiative that took place on the other side of the Atlantic has had a huge impact on several other regions of the world. So we can see in Europe in particular, there's been open data initiatives already in the Netherlands, in the Amsterdam ICU, in Switzerland. They also opened their data following the example of Mimic and following this principle. And during the pandemic, we also saw other initiatives of fully open de-identified data coming up in regions like Spain, for instance. They opened up the repository for COVID patients in HM hospitals from Madrid, and also in Catalonia. Now there are other initiatives that are starting to take place. So in the end, let's remember, if we don't open up our data sets, if we don't apply all that we know about research to the data as soon as we have an answer, everything else is going to be useful, and we are not going to be able to make the most out of the data to apply it for our patients. Because let's remind that we've been digitalizing our data for decades now. During the Obama administration, for instance, in the US, we saw how there was a huge investment for hospitals to be digitalized, so everyone would count with an EHR. But after decades of digitalization, we are lacking interoperability. What does this mean? It means that whenever we move from one hospital to another, our data is not available. And this is a problem, because we saw how integrating the data and having it all on the same format, on the same repository, is the way we derive insights in the most efficient way. So even within a hospital, we see how between departments, these data that are not interoperable are hard to integrate, are hard to exploit, and in the end, it's hard to make the most out of it. So now going back to Andalusia, on this side of the ocean, like you can see here how we are so close to Portugal. We are neighbors from the south. What I'm trying to do is making the most out of this operability that is already happening in Andalusia, because our EHR is fully interoperable right now, meaning I can move throughout the region. I can go from one province to another, and always with my ID, with my health insurance card, I can get all the information whenever I'm being treated in a hospital. But this means that after 2 decades of interoperability, because this started in 2001, we do have all our hospitals digitalized under the same standards, meaning that in a region with the size of Switzerland in terms of population, 8.5 million, after 2 decades, with the people who are deceased, with the people who were traveling throughout Andalusia, now we have 14 million of patients in our electronic health records. ready to be exploited, ready to derive insights from it, because they are all standardized across the whole region. For instance, in terms of the packs of radiology imaging, there are 5,000 million radiology images ready to build better models, to build better prediction algorithms, and to derive insights in the form of tools. So for that to be happening, there is still so much work to do ahead. I think following this principle, which again, I think we don't need to reinvent the wheel whenever we are talking about collaborating around data and open data. I think just looking at the example of Mimic coming from the ICU, which I didn't mention, is leader in terms of data sharing, because they started, the first version of Mimic was released in 2008. And since that, an average of 100 papers are published with the Mimic data. Actually, they did a research and they found out 25% of machine learning publications taking care in healthcare are using Mimic data. They have 25,000 users constantly, and most importantly, they had no legal issue since 2008 when they released their data. So since they abide for principles, why reinventing the wheel? Why starting from scratch? I think this model is very replicable, and it really shown how it could be successful. So in terms of how much time do I have? Because I don't have the timer here. Two?
No.
Okay, good. So in terms of the principles of how to open your repositories, I think these 5 are very important. In terms of security, we of course need to pay attention at privacy, and in terms of privacy, anonymization comes very handy, because it's a way to fully measure how much you did as an organization for making your data not re-identifiable. You can totally measure the possibility of re-identification for a given patient using anonymization techniques. I think cloud integrated development environment should be a good solution for exploiting data for research, data that has been fully anonymized, because it allows you to give the researcher access to their data in a secure environment with the proper tools, and always so they cannot download the data locally, but they interact with this data on a safe environment. And in terms of scalability, for instance, once this is working in Andalusia, it would be easier to scale whenever we are getting more users if we are cloud-based. So I think this is very important in terms of security. Also, we normally have a false feeling of security when we are saying, no, I want our data to be close to me, to be in a server I can see, I can feel, I can touch. But maybe the big techs in terms of cloud are making more, and they are doing things better because they have more funding, they have more resources for security. So if we are not even uploading personal information to the cloud, but only anonymized data for open data projects, I think is totally reasonable to be using the cloud. In terms of integration, we want to make things easier for researchers, so they just go to one place and every single healthcare data that is available for research is there. So they don't need to start wondering who to ask for the images, who to ask for the genomics data, who to ask for text in case they want to do any NLP project. In terms of effectiveness, this is something we forget sometimes. I think there is also a false security feeling when we are talking about legal issues, like the more paperwork we generate means the data is going to be safer. So in that regard, I think having a platform where things happen efficiently and researchers can just accept the terms of use online and sign digitally as fast as possible is going to make it easier for these researchers, but also for the people evaluating the data requests whenever a research project is happening. And then collaboration. I think this is the key. If you create a platform where researchers can exchange the code, I think this was the key of the Mimic project. It was so successful because they were not only making available the data freely and openly, but also they were creating a whole platform around it so researchers could exchange information and could exchange questions, code, and answers in order to derive and make research more efficiently. So all this allows us to derive more knowledge to the data and to have a better understanding of how our population should be treated or should be diagnosed. So again, no data, no answers, no tool. So go there, free your data, and don't forget this, empathize with all the people you need to work with, because normally I'm talking about clinician engineering interaction, but this is much more complex. We need lawyers to make things easier for us, also engineers to make things easier for lawyers. We need policymakers, we need decision makers to better work collaboratively and understand the importance of breaking barriers in order to bring better value to our citizens. So thank you very much.
So, good afternoon to all. And I just told Miguel, I don't know how lawyers can actually make life simpler for us. But anyway, I was referring to the GDPR requirements and data and all this difficulty. And just so I will not forget, a question that I would like Koenraad to have in mind is that I would like a comment at the end from Koenraad. If mayors are angry with you, that you're raising awareness of what they have or have not been doing in terms of crisis management. So anyway, so I will talk to you about health data at a very different level. So my presentation focuses on what we call the health economy. So we've been talking about health data and data quality and why we need data to make our life easier from a micro, let's say, perspective. So how we can take clinical data and use it for the benefit of public policy, of people, of population health, and so on. So my discussion will focus more on the macroeconomic data, and specifically, I will speak to you about why we should make a paradigmatic shift in viewing health expenditure and health activity as an investment in society, in the economy, and in the resilience of our systems. So we'll be speaking about what we call the health economy reporting as a policy tool that connects health data to macroeconomic performance, resilience, and at the end of the day, to wealth of our societies. So just a few words about the institution that I'm representing. So I am working with WifORInstitute, that is a global institute based, headquartered out of Darmstadt, outside of Frankfurt. We have offices in Berlin, Athens, Greece, representations in Boston, Ireland. And what we do is we do impact analysis. So I would like to shift your thinking from just thinking of how we integrate clinical data, from how we can actually look into activity, economic activity related health data, and how we connect these two parts to make good sense out of these things. So at WifORInstitute, what we do is we build a common understanding between different stakeholders by creating a common denominator. So all parties would speak the same language. So what we are actually doing is we're bringing together ministries, political stakeholders, statistical institutes to talk about the data using the same language, meaning the same things. Now, why do we need to invest in this high quality data? This is the question. It's blocked, so you cannot see this question. So recently, through the COVID crisis, we did get a live confirmation of how all economic activities, oh, thank you so much, Maria, how all economic activity is interrelated and affected by health. So disruption, we noticed, was across all economic and social activity, and we all have discussed this. And although this is a reality, health data is not collected in a way that allows measurements of how health affects economic and social performance to that end. An obvious question that comes up is how we fix something if we don't measure it. So data is there so we can measure something that we are willing at the end of the day to try to fix. Now, the answer to this question is that you simply can't fix something if you don't measure it. So smart policies actually are made only if we measure things reliably. And this is what health economy reporting is all about. It's about measuring how health-related activity in our economies, regional, national, or global economies, affects the macroeconomy. Oops. How is this thing moving? Oh, it's not moving now. Excuse me?
That should be okay.
Yes, thank you so much. So how could reliable data collection benefit healthcare providers and policymakers? So without any question, there's a financial dimension of health metrics, health data, and therefore quality should be accounted for if we want to make the right and the smart decisions. So we need reliable data that connect health interventions with their impact. If we do not capture the value of the impact, we really have a very limited viewpoint of what is happening. So this is what is missing in our policy-making processes at all levels of governance, local governments, regional and national governments. So all those scarce societal resources in countries are directed to health interventions. We don't know the return of investments of those interventions. So how can we make the right decisions if we don't know how a policy, how and what is affected by a policy? On the one hand, healthcare providers, healthcare systems, let's say, hospitals and so on, need to prioritize their actions. And on the other hand, economic policy making would be deficient if they do not account for the health parameter. So we're proposing globally for a consolidated economic and health policy with common goals, and this is the missing link, and why we need to have reliable data in order to make these smart decisions. So what's this new perspective? We have been seeing that health expenditures typically have been viewed as a cost, as a political cost actually, and not as an investment for sustainable growth and development. And although 80% of these expenditures for health come from pooled sources, we actually still view it as a cost. So one stakeholder is trying to grab money from the other. And this is a story. So I have, people in health systems actually live this tragedy on their daily lives. So what we are doing at WifORInstitute, we're fostering the paradigm shift in healthcare from a cost factor to a driver for growth, for innovation, for wealth, for prosperity, and at the end, for better health for the population. And we are viewing health economy as a driver for all these aspects. Now, what is the health economy? Think of the health economy as a diverse industrial sector that is comprised by any economic activity, as we see this in the national accounting systems, but both regionally and nationally, that is contributing to healthcare. So we see three big parts. I'm not going to stick on this analysis, but there are three major parts. We have the healthcare economy, typically what we have is hospitals, healthcare practitioners, and so on. Then we have the industrial health economy, that is the pharma industry, Medtech, R&D, and so on. And we have all the service and support industries, retail, health, tourism, IT, private insurance, and so on, that goes into the healthcare provision service. Just to get an idea of what the health economy is all about globally. So you'll be shocked. The health economy is contributing 7.6% to global GDP as an industrial sector. We're talking about $6.3 trillion, and this is twice the GDP of France. So it's a big sector. And in terms of employment, it is contributing 5.7% of the global employment. And this is something less than 200 million people working in this sector. So that's like the labor force of the United States and Canada together. So we're talking about very powerful industrial sectors. Whatever we do, whatever we speak about, is very aligned with what WHO, that we're closely collaborating with, is doing. So we believe that the health economy has a very essential social and economic role, and it has a positive impact on the economic performance of other sectors. So what €1, $1, £1 spent in a regional economy does to another sector, mining sector, automobile sector, tourism, is actually what we need to measure, to monitor. And for this reason, we need this reliable data. So we need to structure databases, as we have been doing for the past 12 years with the Federal Republic of Germany, throughout all the regional governments as well. This is a very simple, however, very insightful graph. This is time series of health expenditures and global GDP growth rates as a percentage of GDP. So what you see here is that during the crisis, 2008, 2009, during the pandemic crisis, 2020, we saw a collapse at GDP growth rates. Okay, but what happens when the global current health expenditure as a proxy to the health economy grows? Then with a time lag, you see growth rates picking up. This tells all the story. I think, this is all the story to be told. I was honored to be a co-author for a paper recently that we presented at the G20 presidency, along with my wife, her colleagues, and Professor Rifata Tun and other distinguished colleagues. So we entitled this paper, "If we can't measure it, we can't fix it." What is it all about? This is available, by the way, and I can make my presentation available to everyone. There's a link there, and you can see this paper. It's a very simplified way that speaks about how we assess at all levels, and I will be very specific in half a minute, of health investments, health interventions. So we need data in order to be able to calculate returns of investment. And if we have these returns of investment, only then we can make smart decisions. So this is a simplified view of our 5-step framework of how to assess impacts of health investment. So health investment, siloed, just sitting there in itself, doesn't say much. A health investment should be viewed in terms of its impact. And the impact of the health investment is the return of investment to the economy, to society, and to the environment. So I'll show you in a few minutes what we're doing on that side, on integrating these 3 factors that I just mentioned. So the first stage, by the way, all these stages are connected with SDG goals. So you see SDG 8, 13, and 3 in my table. So the first step is to have this macro picture of what is the health economy, what is all the economic activity measured in GDP, gross value added terms, and employment, that is contributing to society by the activities that cater to health at the overall sense. So once we know that, we know the size and we know what's going on, we have a structure. So this is the data, the first big macro data structure that we need to set in place. Second stage is we're looking into the interlinkages between the health economy subsectors themselves. What happens if we pump £1 into the health system of Wales, let's say in your case? 2 minutes, can I have 4 minutes?
Yeah.
Thank you, because I'm negotiating. So I'll wrap it up. So yeah, sure. So interlinkages within the health economy. What happens if we put £1 to one sector with another sector, with a pharma sector, let's say, and so on? What are the spillover effects beyond the health economy? What happens to mining, to automobile industry, to tourism, to banking, and so on? What happens with the climate impact? Because there's both ways relationship of climate and health burdens in societies. And at the end, we have this microeconomic approach: is what is the social impact of a specific intervention in terms of GVA and employment? So let me just rush it through now. So at the center of all the discussion is SDG 3, better health for all people. And this is connected, as we saw, with all other goals in our view. Now, recently, we measured the contribution of the Medtech industry of the federal German state. So what we did is we saw how the Medtech industry contributes in terms of social, environmental, and economic terms to the local, national, and global supply chains. So this set the precedence for a new benchmarking of how to measure the contribution of a health system, of an industry, of a company. Okay, so this is setting the new. It is instigating a new paradigmatic shift in viewing these expenditures and this activity in a different viewpoint. Just to give you for Germany, every €8 produced is part of the health economy, and every 6th job is part of the health economy. It's big, it's powerful. These are the numbers for the European Union, 9.6 and 12.5. All your indices should have been benchmarked with this if you're related to health in any way. That's my suggestion. These are just some statistics of our recent calculations for Germany. So we're talking about 390 billion euros per year for the health economy. And these are the health economy shares, just to get an idea of various countries. So you see there's a big spread. Other countries pump in money, others don't. And we see the results. The benefits. Well, the benefits is that we have a starting point for a new objective dialogue between all stakeholders. We have an evidence-based insight and monitoring to support decision-making of economic and health policy jointly, and I'm emphasizing this. We can have comparability with other important sectors of the economy because we're measuring everything in terms of gross value added, GDP, and employment. And we also can see for industry the social, economic, and environmental assessments. And this is a macroeconomic approach of the future that can give us that can support and give value-based policy decisions. And again, we are reframing health expenditure as an investment, starting from strengthening growth, stability, and so on, strengthening the value chain of the health system itself, generating positive effects for the overall economy, at the end, improving healthcare. I mean, this is a win-win-win-win. And as Dr. Jakob of the WHO says, I love this, is, health investment is the smartest investment. Why? It just pays off. That's why. It pays off society to growth and to everything else. Thank you so much for your attention, and I'm open to any of your questions. I held it 4 minutes, I guess.
Just a little bit under.
Thank you.
Okay, so we have, if you don't mind, one question in person. Yeah, and then we also have some online. But let's go with this. Sorry, go on.
Hi, I'm Rachel Powell from Digital Health Academy. Thank you to all of the speakers. It was all very interesting. And my question is probably for you, Emmanuel.
Sure.
In terms of I'm converted. I'm totally in agreement with what you're saying. Sounds really interesting. So I'd love to find out a bit more. I guess my question was just in respect of how you would factor in the waste element in terms of NHS spending. And we know, and I am an advocate for spending more in the NHS, so I'm not talking about cutting costs at all. But also we know that's some waste in the system. Just how do you factor that in?
Good question. It's a great question. So by virtue of the way that the data input is structured for this exercise, so we are working with input-output tables, so we can actually locate, identify waste by looking at the ROIs, the returns of investments of the individual interventions. So for instance, if you have a campaign for a vaccination policy, we could actually pull out the contribution of this vaccination policy under a crisis or another normal situation, and how this contributed in terms of gross value added in your region, in your nation. So we do it by virtue of focusing on the impact side of an intervention. So that's how we locate waste. Thank you for the question.
Do we have any more questions from you? Yes.
I'm a student here at WMIS. What I want to ask was in relation to the health data that all your countries have. What is the position of government in relation to the who owns the data that you collect?
Yeah, that's always a tricky question, of course, who owns the data. In Flanders, we are now investigating to set up a new kind of project that's called solid technology, where every citizen can put his or her welfare data, well-being data, healthcare data on that specific pot, and the person itself can decide with whom, why, when to share that data, to share that information with private organizations, public organizations, and so on. For myself, I find it rather difficult. If you look, people haven't any problem with sharing their data with commercial players like Google or Facebook or Amazon to get the next best deal and the next best offer. And look, this is a picture last year with your wife and your children where you were in that region and you had a nice visit and a nice, you visit a restaurant. But on the other hand, when we look at COVID-19 and the aspect with respect to contact tracing, there wasn't that huge take-up of every citizen to share the information with the government to be able to tackle the issue and to take action on it. And I think that when I see that during COVID, we were able to change the legislations much quicker because in Belgium we have different regions, different legislations, federal and so on and so on. But we were able to put the legislation much quicker, faster into action due to COVID-19. So we were able to gather a lot of data. For me, as I've shown, it was very interesting because we could show the added value of what is now a data-driven policy on a government aspect. So you had the pendulum that was swinging on the other side of, no problem with sharing information. But now COVID-19, it's still not completely gone, but we are going in a good direction, hopefully. But now you see that the pendulum again is switching to the other side, and that the DPOs and the laws, the lawyers and so on, you could do that 2 or 3 months ago with no issue, but now it's another game. And what I'm a little bit afraid of is that, who owns the data? I don't know who owns the data. There are different debates and technology and so on. What I'm a little bit afraid of is that when we are going forward with that solid technology, and every information of an individual is put within that specific data pot. And for instance, there is a new pandemic within 2 years or 3 years, and I'm as a civil servant, I need that information of are you vaccinated, who did you visit, are you healthy, and so on. And that person says to me, you can't get my information. And say, for instance, that 70 or 80% of the whole population does that same action, I won't be able to make good policy. So we need to see if there is some laws that we can, between brackets, force individuals to share their data within a specific situation. So for me, yeah, the yin and the yang, it's not that easy. So I'm still struggling with that.
I think from a Spanish standpoint, but I think this applies to other European regions. Theoretically, the data belongs to the patient. That's what every, I don't know, health system is always repeating endlessly. But I think that the reasoning shouldn't be ending there. Like, we need to go a little bit beyond. Like, okay, the data belongs to the patient. So that means what? Like, I have a relative who is admitted to the ICU, and they are like in the middle of one of the worst waves of the pandemic. So my relative is 80 years old, and they give a pen drive with the data to my relative. So why would that be useful at all? I think we shouldn't continue the reasoning and say, okay, the data belongs to the patient. So we as researchers, as part of the governmental administration, we should be making the most out of this data so we can better treat these patients. So because the data belongs to them. So what they really want, what is the best treatment they can get, and efficient diagnosis. I think that's the answer. So we need to change the debate, and we need to talk about the right to privacy versus the duty to help. This is something Koenraad was mentioning before, and we need to start talking as well about the harm of not sharing data, because this is something that is happening right now. Okay, these are all the risks. Okay, we know there are risks of re-identification of anonymized data, but there are also risks of your airplane to be crashing. Still, you're using it on a daily basis, and planes are flying every day, but data is not being shared for researchers. GDPR, this was something Emmanuel was mentioning before. GDPR, I think they didn't take into account the users' opinions, because then the researchers and the data scientists were going to be facing GDPR, and I when I read GDPR, it's clear to me that they didn't take into account the end user's opinion, which is something basic when you build anything. Who is going to be the user, and how do you take their needs into account? And in terms of big companies, yeah, of course, we need to be protected from Facebook, from Meta, from Google, from Amazon, but still there should be some kind of category within the GDPR explaining how data should be used for research, for healthcare, and to be done this on an efficient way, because we lost so many opportunities during the pandemic because data access was too slow and didn't take place.
If you would like to get a quick perspective of the same question, sure.
One last question, and we have questions also from online, so
Okay.
try and pack as much as possible.
Oh, okay. So as far as the data that I was speaking about, it's public data, statistical data from the National Accounting System, and it's also company-owned data. So if you connect this data with the other data sets, you can make a lot of sense and a lot of policy decisions. So we have very clear ownership rights. Thank you.
I have a couple of observations and a question to you, Emmanuel. So, Miguel, you're absolutely right. I think we have a complete imbalance between talking about risks, perceived risks, no real degree of brutality, we don't know about actual harms, versus value. And I certainly believe that people suffer or die every day because we cannot generate the evidence. So it's a fact, as far as I'm concerned. I don't think we have to prove that. But this whole conundrum about ownership is not helpful. As a professional, but also as a patient, I actually don't want to own my data or control it or host it, God forbid. What I do want is equitable access to that data and the information, so I can have a balanced discussion with my care providers and have adequate care plan and so forth. I don't have to control the data to do that. And actually, there's a lot of data that I generate, data by me or us. Most of this data is the transactional nature of healthcare. It's data about us. It's actually generated by healthcare providers and institutions. Why is that mine? I don't actually understand that conundrum. I think it's actually more of a philosophical debate to get into, and I don't think it's actually very helpful to what we're trying to achieve. And the last comment to Koenraad was, I think it's unfortunate that we saw the mass ditching of things like the COVID-19 vaccine passports and apps, because they were a conduit potentially, because people were using this, a sizable population was using this in Europe and elsewhere, and then they just stopped. And it was a real unfortunate situation, because that was a real opportunity to say to people, look, how this works in COVID-19, this could be applicable to other disease areas, but no, we saw our governments ditching them, like, get rid of these, we don't want to talk about them anymore. Very unfortunate. And then my last point, question to you, Emmanuel, also scanned your quoted paper, fascinating. You mentioned quite rightfully the rise in investment in healthcare and the proportionality lagged, of course, rise in GDP. One of the big differences with COVID-19, of course, is that a lot of people were sick of working age or contributing to the economy. But the challenge is that outside of a pandemic, many people who are sick are often seen as a drain. They're not necessarily able to work or work effectively, and they're not contributing as seen to GDP, and they're requiring social and healthcare costs and so forth as well. So it's seen as a drain and not an investment. What's your views on that in terms of, because that's, I think, part of the problem outside of a pandemic, is that you attach this to GDP, quite understandably, a lot of people who are chronically sick are often seen to be draining and not an investment, and so not contributing to GDP in society.
Yeah, I see your point. So first of all, if I might just complement your previous thought on something, I think that data ownership is just an intermediate phase of the process. What really makes sense for people is to have ownership of the right to decide about their health. And they really can't make any sense out of just raw data. So it's an intermediary product, let's say. So that would be my, absolutely am aligned with your thought at this. Now, coming to your question on the burden, on the investment burden that chronic, let's say, patients would impose, our analysis actually reviews how a specific intervention would be able to reduce the burden to the economy and to society. So if we assume that chronic, let's say, patients have an X burden, with our intervention, this will be X minus Y in terms of the burden. So I need to know how much that is. And as long as I know and I have transparency, then we can make a rational decision as a society, as people, as governments, what we want to share for this reduction of burden. Because if we don't have enough money, if we don't have enough resources, we might just end up doing an ad hoc management of those resources. And that's worse than just having a rational decision and a transparent decision to people. So we might say that 10% of these resources will actually go to the chronic patients. Why? Because this will alleviate society from that burden. So we know that. So that's my response, if that satisfies your question. Thank you.
I have one short remark. The right to decide if your information can be shared, I'm not convinced of that. During COVID-19, there was a certain period in Belgium that if you visited a pub, you needed to fill in some information. So if there was a contamination afterwards, you can be reached. I can assure you that there were a lot of Donald Ducks and Mickey Mouse running around in Belgium. So again, we need to find something that is feasible and that you take into account the right to decide. But even in a moment of a pandemic crisis, that you can infatuate your neighbors or people that were sitting in a public area, citizens put in their information as Donald Duck or Mickey Mouse. So the right to decide, I think you have to find the right context where the right to decide is okay, and another context where the right to decide is a question mark.
Absolutely, you're right in this.
In the interest that we have taken quite a bit of time and we still have a lot of questions submitted online, I would like to ask for one-liner conclusions from the panel and to say to the people online that have submitted questions that we can relay these to the speakers and we can get back to them post-session. And if the individuals in the room still have a lot of questions, which I'm sure everybody does, we can discuss them in the break or after lunch because I'm cautious of the time. So in one-liner, last conclusion, last thoughts from you to everyone.
If I can be the first one wrapping up, I would say in terms of, because whenever we talk about data answers, we need to mine this data and derive insights from it. So in terms of data platforms, let's not reinvent the wheel. Let's look at success cases and just mimic them in case they are working. And let's stop talking about the potential risk and let's start talking about the harm of not sharing data.
Yeah, for me, the right to decide sharing data should be put in the right context when data needs to be shared.
And from my part, in order to make the right policy decisions, we need to measure impact-related evidence. Data in themselves are not adequate to tell the story. The story is told by the impacts. Thank you.
Thank you so much. Thank you everyone online and everyone in person. This brings the session to a close and
thank you very much.
Thank you very much.
Thank you.